So we are very fortunate to have Dr. Vera joining us again, and we'll be speaking about kind of a whirlwind tour of cardiology. Yesterday we had kind of a more focused coronary artery disease talk, but we'll cover a lot of different topics, I think, during the course of this. Um, and if you want to go ahead and if you could share your slides, if you'd prefer, we could share, and then I could drive whenever you tell me to advance. But oh, perfect. Okay, very good.
All right. Is it in the presenter mode?
It is. It looks great. Yes. By which I mean, I think it's working presenter mode for you. We just see the slides.
Yeah.
And then we will launch the polls with each of your questions. Steve will
Okay.
handle that.
Yep, sounds good.
Give them about 20 seconds or so to answer, and then you'll see the results.
Should I go ahead and start, or should we wait a little bit?
Why don't we go ahead and get started if you are ready?
Okay. All right, so thanks for having me for this lecture again. So just to kind of go over the breakdown of the medical kind of content for the boards, cardiology is the most heavily tested. So it, of course, is very important to have a good understanding of cardiology. Here's kind of the sub breakdown within cardiology of what's tested. And you'll note that hypertension is the most tested, and that actually falls under nephrology and some other categories as well. So certainly that will be tested frequently. All right, so I'll just start case by case. I started off with the most sort of practical questions in the beginning that are most relevant to people's clinical practice. And then at the end, some of the questions are a little bit more esoteric, but still could be tested on the boards. All right, so we'll start off with a question. We have a 75-year-old male with a past medical history of coronary artery disease with a prior CABG, heart failure with a reduced ejection fraction of 30%, hypertension, hyperlipidemia, diabetes, who presents to clinic for follow-up after a recent admission for heart failure. His medications include carvedilol 3.125 BID, lisinopril 40 milligrams daily, spironolactone 25 milligrams daily, and empagliflozin 10 milligrams daily, and Lasix 20 milligrams BID. Vitals in clinic show a heart rate of 55 beats a minute and a blood pressure of 145/80. On exam, his JVD is normal. He has normal renal function and potassium on recent labs. What medication change do you recommend? So A, stop lisinopril and start sacubitril valsartan 4951 the following day. B, stop lisinopril and start sacubitril valsartan 4951 after 36 hours. C, stop lisinopril and start losartan 100 milligrams daily. Or D, increase furosemide to 40 milligrams BID. All right, so I think I'll go ahead and end the poll. Looks like most people said B, which is the correct answer. And I'll just move that. Are you seeing the polling questions? Side. Okay. All right, so this is kind of a summary of how you convert patients from ACE-ARBs to an ARNI. And essentially, if you're converting to an ACE inhibitor, you do have to have a 36-hour washout period before starting Entresto. And in terms of the dosage that you would select, if the patient is on a very low dose of an ACE, then you would switch to 24/26 of the Entresto first. If they're on a high dose of lisinopril or of an ACE inhibitor, you can start with a 49/51. So in this patient, he was on 40 milligrams to begin with. So we were able to start with a 49/51, and then we can go ahead and up titrate further if needed. If they're on an ARB, then you can just go ahead and switch them right away the following day. And this was studied in the Paradigm HF trial, which showed that ARNIs are superior to enalapril in reducing the risk of death and hospitalizations for heart failure in patients with an EF less than 45%. Here's kind of the data, the clinical trends, so reducing the primary endpoint of death from cardiovascular cause, as well as hospitalizations and all-cause mortality as well. So it is a class 1 indication in patients with HFrEF with NYHA class 2 to 3 to use ARNI up front to reduce mortality and morbidity. And then also if patients have HFrEF and they're on a stable dose of an ACE or an ARB and they're NYHA class 2 or more, to actually go ahead and switch them to an ARNI. So 2 weeks later in follow-up, the patient has a stable chemistry. Blood pressure is 135/80. What is the next best step in management? Is it A, to increase the sacubitril valsartan to 97/103? Is it B, to continue current therapy, or C, to start amlodipine? Okay, so looks like most people are saying A, which is the correct answer. So in patients with heart failure, we really want to optimize their GDMT to max tolerated doses. It's not necessarily based on a blood pressure cutoff of 130/80 like we may for other patients. It's really just the max tolerated dose. But certainly a blood pressure of 135/80 would be appropriate to further up-titrate their GDMT. Now, sometimes patients can be a lot more sensitive in their blood pressures to ARNIs versus ACEs and ARBs. You might even see that their creatinine may bump a little bit, and sometimes when you switch for an ACE or an ARB to an ARNI, you can sometimes decrease their diuretic dose. So if they're on BID, they might be able to tolerate just once daily instead because it has that little bit of a diuretic effect, and it can sometimes help mitigate any sort of dizziness that they might get with the ARNIs. And so, yeah, certainly sometimes patients can have lower blood pressures with the ARNIs compared to the ACEs and ARBs. So I'm a little bit slower with my titration and a little less aggressive, I would say. But still in a patient with blood pressures of 135/80, we'd want to max them out. All right, so moving on to the next case. I have a 70-year-old African-American male who recently was diagnosed with heart failure with reduced ejection fraction of 25%. He's currently taking carvedilol 6.25 milligrams BID, sacubitril valsartan 97/103 BID, spironolactone 25 daily, and empagliflozin 10 a day, and Lasix 40 milligrams BID. He continues to have exertional limitation, is an NYHA Class 3. Vital signs include a heart rate of 55 beats per minute and a blood pressure of 140/80. What is the next best step in management? Is it A, to add amlodipine 5 milligrams daily? Is it B, to add amlodipine 10 milligrams daily? C, to add chlorthalidone? Or D, to add isosorbide dinitrite / hydralazine combination? All right, so looks like most people did say D, and that is the correct answer. So in this patient, he's pretty much on quadruple therapy in terms of GDMT for heart failure, but still has blood pressures that are elevated. And so the next step in therapy for specifically for an African American is the combination use of Bidil. And this was studied in the AHEF trial, that the addition of the fixed dose isosorbide plus hydralazine to standard heart failure therapy improves survival specifically in African Americans. And so it is a class 1 indication. Certainly in practical life, if you have a patient who struggles to take TID medications, I will use amlodipine, for example. It's an easier blood pressure medication, if the blood pressures are still elevated, that is. But sort of by standard guideline practice, we would prefer the patients use the Bidil medication if they're African American. Another patient category that you would use this medication combination for is patients who have sort of labile renal function that doesn't quite allow them to be on an ACE, ARB, or ARNI. Potentially they have too much hyperkalemia. And so this would be sort of an alternate afterload reducing therapy sort of in place of the ACE, ARB, or ARNI for those patients. All right, so the next case. Case 3, we have a 68-year-old male with a past medical history of hypertension, hyperlipidemia, prior tobacco use, COPD, who presents for chest pain. The pain is described as chest pressure, lasting for a few minutes at rest. It does not appear to be worsened with exertion. His ECG is shown below. He reports he does go on daily walks for exercise and will experience shortness of breath, but not chest pain. On exam, he has significant end expiratory wheezes. His most recent lipid panel shows an LDL of 100, and his ASCVD risk score is 25. He is hesitant to start a statin. What is the next best step for this patient? I've shown the EKG here that you can all see. So, is the answer A, exercise treadmill stress test? Is it B, a myocardial perfusion test with pharmacologics test? Is it C, a CT coronary angiogram? Or D, no testing is necessary? Okay, so a little bit more split on this question, which is what I anticipated, and the answer is C. And so the main points here in terms of ischemic workup is that if you have a left bundle branch block at baseline, which is what this patient has, you cannot do a plain old treadmill exercise stress test, ECG stress test alone. You will need some associated imaging because the EKG with the left bundle branch is not sort of sensitive to allow you to look for ischemic changes. So that takes out the plain old treadmill ECG test. A pharmacologic stress test with rigadenosine is contraindicated in patients who have active wheezing because the rigadenosine that we give is a adenosine agent that can increase bronchospasm. I would say testing is indicated in this patient. He has multiple risk factors. And so really the best test for this patient is a coronary CT angiogram, which will give you sort of identification of percent narrowing of stenosis, et cetera. And the benefit of that test over any stress test, let's say, is that it will show if the patient does have any coronary calcifications, right? So if a patient has a negative stress test, that doesn't mean that they don't have non-obstructive coronary disease. But a CT coronary angio will tell you, hey, this patient's chest pain may not be from obstructive coronary disease, but they do have non-obstructive disease. And especially in a patient who doesn't really want to be on a statin, that probably should be, that CT scan can sort of provide a little bit more data to the patient that may hopefully convince them to get to be put on a statin. So the next question is that a CT coronary angiogram reveals that the patient has a calcium score of 500 Agatston units with non-obstructive disease. The maximum luminal narrowing is 25 to 40%, and this is seen in the LAD, the circumflex, and the RCA. There is no left main disease. His blood pressure is consistently 145/90. And what is the next best step in management? Is it A, to recommend initiation of a low-dose statin? B, recommend initiation of a moderate to high-intensity statin? C, to recommend initiation of antihypertensive therapy? D, recommend an invasive coronary angiogram? Or E, B and C? So remember that the patient had an LDL of 100 and an ASCVD risk score of 25 as well, and the blood pressures are consistently 145/90. All right, so it looks like everyone got it correct. The answer is, in fact, B and C. So the patient does have non-obstructive coronary artery disease. So you would want to put them on a moderate to high intensity statin for primary prevention with a goal LDL of less than 70. And then you also want to treat these patients with a blood pressure goal of less than 130/80. And so you would want to start an antihypertensive agent. You wouldn't proceed to an invasive coronary angiogram because the patient doesn't have obstructive coronary disease, as long as the study is felt to be interpreted accurately. If the patient did, for example, and here's just kind of the ASCVD guidelines in terms of primary prevention. So, you really, if the patient is a diabetic, you're going to always put them on a statin therapy. If their LDLs are consistently above, 160s, you're also going to want to put them on a statin. And then for all others, you really want to use the ASCVD risk score to help guide your kind of therapy. Another point on this slide is that you can use a coronary artery calcium score in patients who are kind of intermediate and maybe don't really want to be on a statin. And notably, that's different from a CT coronary angiogram. So a CT coronary angiogram is given with contrast. So it will give you the calcium score, but it will also tell you the percent narrowing to tell you if there's obstructive disease or not. So the coronary CT angiogram should really be in symptomatic patients who you want to answer the question, is obstructive coronary artery disease causing their symptoms? However, in this scenario, a coronary artery calcium score is a low-dose CT that's non-contrasted. And so this shouldn't be used in symptomatic patients. It should be used in asymptomatic patients who you're having discussions on primary prevention with them and discussing statin therapy, et cetera, and who may feel that they don't want to be on a statin, or perhaps you think they should be on a statin even though they have a low risk, but perhaps they have some risk enhancers, like they have a family history of premature coronary artery disease, they have an elevated lipoprotein A, they have history of preeclampsia, things like this. So that would be sort of the distinction between those two imaging studies. And then in terms of, secondary prevention, so once the patient does have clinical ASCVD, you really want to kind of target their statin therapy to their LDL goal, typically less than 70 and oftentimes less than 50, especially in diabetics. And this sort of gives guidelines for if on max statin, they're still not reaching their goals, what additional therapies can you add? Ezetimibe, PCSK9 inhibitors. And then here's sort of the recommendations for blood pressure control, especially based on ASCVD risk score. So if they have an ASCVD risk score greater than 10, you definitely want to be more aggressive with pharmacologic therapy for a goal blood pressure less than 130/80. Okay, next case. We have a 73-year-old female who presents for follow-up after an admission for heart failure exacerbation. This is her third admission this year. Her echocardiogram shows a normal LVEF of 65% with stage 2 diastolic dysfunction, with an elevated left atrial pressure and intermediate right atrial pressures of an 8 millimeters mercury. Her vitals show a blood pressure of 120/75, a heart rate of 80. Her recent labs show normal creatinine and a potassium of 4.3. She is not a diabetic. She is currently taking losartan 100 milligrams daily and Lasix 80 milligrams BID. On exam, she appears just mildly volume up. So what additional medications would you recommend? Would you recommend metoprolol succinate, 25 milligrams daily, spironolactone 12.5 milligrams daily, and empagliflozin 12.5 milligrams daily, D, which would be both B and C, spironolactone and empagliflozin, or E, adding metolazone 2.5 milligrams daily? All right, so it looks like we're kind of split between just empagliflozin alone or empagliflozin and spironolactone. So the answer is I would recommend D. And so this is kind of based on the most recent heart failure guidelines, which essentially say if patients have HFpEF, diuretics are used as needed for volume control. And then SGLT2 inhibitors get a class 2A recommendation. And the other agents like ARNIs, MRAs, and ARBs get a 2B indication. And I didn't want to present all of the data behind this, but essentially the support for the SGLT2 inhibitors comes from Emperor Preserved and then the Deliver trial, which looked at empagliflozin and then dapagliflozin. And what it showed is the overall composite primary outcome of reduced mortality and heart failure hospitalizations was positive. However, when you look at the individual outcomes, it's really all driven by reduction in heart failure hospitalizations. But because the composite was was positive, it gets a 2A recommendation. It doesn't get a class 1 indication because it did not reduce mortality necessarily. Now, the MRAs, that was studied in the TopCat trial, and that was a negative study. The primary outcome was not positive. However, if you looked at the individual outcomes of these individual components, there was a reduction in heart failure hospitalization. So that's why it gets a 2B indication rather than 2A. My goal in patients who are on loop diuretics with HFpEF or HFrEF is always to get them down on their loop diuretic as much as possible because that doesn't really improve their mortality. Whereas the ARNIs, whereas the SGLT2 inhibitors and MRAs have some more data to support their use. And so typically when I try to get patients on both of these agents, I'm also again able to drop their diuretic dose. So if they're on BID dosing, I may be able to get them down to just once daily dosing with the addition of both of these agents. So I don't think the answer would be necessarily wrong if you just chose an SGLT2 inhibitor to start with and then MRA later. But personally, in my practice, I would just go ahead and start patients on both and potentially try to decrease their loop diuretic in the process if I can. Now, in terms of ARNIs for HFpEF or HF mid-range EF, that also gets a 2B indication, and this was studied in the Paragon HF trial, which was again a negative trial, but it did show a trend towards benefit in females and people with EF on the lower end of the spectrum. And so that's kind of the second chart here that shows for women and people with a lower EF spectrum, you might consider an ARNI for additional therapy. Okay. Case 5. We have a 46-year-old male with a past medical history of OSA, hypertension, hyperlipidemia, who presents after a recent admission for chest pain and new onset paroxysmal atrial fibrillation. During the admission, the patient had a myocardial perfusion study that was negative for ischemia. He was noted to be going in and out of atrial fibrillation during the admission with associated symptoms. He had an echocardiogram that was unremarkable, an event monitor which shows 20% paroxysmal AFib burden with elevated rates when in atrial fibrillation. Currently is in normal sinus rhythm and has a normal QRS and QTC interval. He is currently taking metoprolol 25 milligrams BID and wants to be on the least number of medications that he can. What is the next best step in management? Is it A, to start oral anticoagulation, B, to increase metoprolol to 50 BID, C, refer to cardiology to consider antiarrhythmic use, D, refer to cardiology to consider ablation, or E, all of the above? All right, so it looks like most people are saying E. I think many times when the answer is all of the above, it tends to be the answer. But yes, that is indeed the answer. So this patient's CHA2DS2-VASc score is going to at least be 2 for diabetes and hypertension. So anticoagulation is certainly indicated. You want to increasing the metoprolol to 50 BID is reasonable until they can see us because that will not necessarily help prevent them from going in and out of AFib, but at least to control the heart rates when they go into AFib. And the event monitor showed that they had elevated rates when they're in AFib. And then in terms of what are we going to do when we see them in cardiology clinic? Are we going to put them on antiarrhythmics? Are we going to ablate them? Well, in this patient, it's a young patient, and they're symptomatic from their AFib. And so the AFib guidelines published in 2023 actually gave a class 1 indication that in younger patients with fewer comorbidities and symptomatic paroxysmal atrial fibrillation is that you can actually use ablation as first-line therapy. And then also, overall, in general, it's a class 2A indication for symptomatic AFib patients to use rhythm control to improve symptoms. So I think ultimately for this patient who wants to be on the fewest medications as possible in the long term, an ablation makes the most sense. However, oftentimes there's delays in actually getting that scheduled. And so in practicality, treating with an antiarrhythmic up front until the ablation can be complete and then allowing them to come off of their antiarrhythmics afterwards would kind of fit this patient's goal of decreasing the amount of medications they would use. I also included a few details in this slide that, probably would not be tested on. But in terms of the choice of antiarrhythmic therapy, we do need to know what is their QRS, what's their QTC, to help us decide on what antiarrhythmic we can use. And then also excluding obstructive coronary artery disease is needed if we want to use something like flecainide for a patient. So always helpful if you're, referring someone for AFib to make sure we're getting a resting EKG, not just the event monitor, because we really do need to look at that QTC, the QRS, to kind of make those decisions on antiarrhythmic options. Okay, case 6. So those questions that so far kind of are more practical questions that you're all probably going to use in your day-to-day practice. The rest of the questions are a little bit more obscure, probably not a lot of stuff that you're going to be necessarily seeing and managing, but definitely can be tested on the boards. But I think this is a good halfway point to just stop if there's any questions, and then we can move forward to the rest of this cases. I don't think I can see the questions. Um, Let me see if I can. Yeah, I think when I'm in sharing mode, I'm not able to see the questions in the chat. Are there any questions in the chat? No? Oh, here we go. Let's see. Now I can see the chat, it looks like. Okay. Would a light AFib burden change your management? Yeah, so that's a good question. I think that it's really based on symptoms. So if the patient is very, very symptomatic, even with a low AFib burden, I think it would be reasonable to consider antiarrhythmic therapy. Now, if the patient is asymptomatic with a low burden of AFib, which is not something that happens infrequently, it can be fairly frequent. I think at that point, the guidelines or the data does suggest that early rhythm control, even in asymptomatic patients, is beneficial. However, I think that if the burden is very low, I would probably focus more on risk factor modification, which I'm going to do in all of my patients, but things like lowering their blood pressure, treating their sleep apnea or screening them for sleep apnea first and foremost, and then weight loss and working on those things and reassessing the burden. Oftentimes, if you do those things, the burden stays the same or goes down. But if those things are kind of uncontrolled, the burden may go up. So I think that's how I would approach a very low burden, let's say less than 1% burden, really based on symptoms or no symptoms. All right, I don't see any other questions. So I can move on. Are you still able to see my screen? Okay. All right, I will go on to the next question. Let's see, do I need to drag questions over? Okay. So we have a 50-year-old male who presents with progressive exertional dyspnea and chest pressure. He has no significant past medical history. On exam, he is noted to have an irregularly irregular rhythm. He has a 3 out of 6 crescendo decrescendo systolic murmur at the left lower sternal border. When squatting, the murmur decreases in intensity, and with standing, the murmur increases in intensity. With hand grip, the murmur decreases in intensity. The blood pressure is 126 over 80, and the heart rate is 90. The EKG I'll show next, but just think, what is the most likely diagnosis? Does this patient have A, a bicuspid aortic valve with stenosis, B, hypertrophic cardiomyopathy, C, tachycardia-mediated cardiomyopathy, or D, pulmonic stenosis? I will go to the next slide and show the EKG. All right, and then back to the question. All right, so most people said B, which is in fact the correct answer. So you're getting tested on your knowledge of murmurs. So basically, you have the systolic ejection murmur, and the differential will typically be bicuspid aortic valve or hypertrophic cardiomyopathy. And so what happens with the murmurs? We will kind of go over that. But first, I want to ask a secondary follow-up question. So the patient has a transthoracic echocardiogram, which showed normal left ventricular function with evidence of asymmetric septal hypertrophy. The septum measures 2.5 centimeters. He is also noted to have a left ventricular outflow tract obstruction with a peak gradient of 40 millimeters mercury. What is the next best step in management? Is it A, start him on metoprolol 25 milligrams BID and apixaban 5 milligrams BID? B, start him on metoprolol 25 milligrams BID. C, order an event monitor. D, A and C, or E, B and C. All right, so very split between D and E. So basically, you were not sure if the patient needed anticoagulation. So we'll go over that. All right, so just in terms of pathophysiology and things like that, hypertrophic cardiomyopathy is a condition where you have hypertrophy at various areas of the heart. It could be septal, it could be apical hypertrophic cardiomyopathy, but in the classic sort of septal hypertrophy situation, what happens is that not only does the patient has the hypertrophy, but they're also typically born with some degree of abnormality of their mitral valve. That could be that they have an anterior displaced mitral leaflet or they have some redundancy of their chordae. And so those two combinations of things can cause what we call SAM, or systolic anterior motion of the mitral leaflet. And the reason being is because when you have this narrowing of blood flow as it goes out of the LVOT, it causes this turbulent flow and this flow acceleration. And when you also have this sort of floppy, anatomically abnormal anterior mitral valve, the anterior leaflet, which is right there near the LVOT, can get sucked up into the LVOT and cause obstruction. And that's really what gives you that gradient. And at the same time, you can get this posteriorly directed mitral regurgitation, which you can see here. And so it's essentially a dynamic outflow obstruction. It can worsen when the cavity gets smaller in size, and it can be relieved when the cavity is not as small in size. And that sort of speaks to what our medical therapy is. But in terms of the murmur, the keys here to distinguish between a dynamic outflow obstruction from HCM versus a fixed obstruction from aortic stenosis is that anything that makes the cavity smaller or decreases the preload to the heart is going to increase your HCM murmur. On the contrary, anything that increases the preload and the flow going out of the valve is going to increase the aortic stenosis because that's a fixed obstruction. That's not going to change based on loading conditions. So if you increase the preload by squatting or raising your legs, you're going to decrease the HCM murmur because the increased preload kind of makes the cavity bigger and decreases the obstruction. However, with aortic stenosis, if you're increasing preload, you're just increasing the amount of blood that's going out of this fixed stenosis, and so your murmur is going to go up. On the other hand, if you're decreasing your preload, so you're standing, you're doing Valsalva, you're going to make your obstruction worse with HCM, and so you're going to increase your murmur. Whereas if you're decreasing the preload, decreasing the flow out of the fixed aortic valve obstruction, you're going to decrease that murmur. And then hand grip, which increases the afterload, will actually decrease the murmur in both situations. So these are kind of the keys in differentiating the murmurs in your patients. And so it also kind of speaks towards diagnosis and treatment. So frequently, if patients don't have a resting outflow tract obstruction on an echo, we will have them Valsalva to see if we can bring out that obstruction. So some other pearls about HCM that was sort of tested in this is that it's a class 1 indication to anticoagulate all patients with HCM regardless of their CHA2DS2-VASc score. So I intentionally chose a younger patient without too many risk factors that their CHA2DS2-VASc may have been 0, but really it doesn't matter. All HCM patients, if they have atrial fibrillation, will need to be anticoagulated. Another thing that was asked is an event monitor. So an event monitor for this patient would not only be beneficial because they're in atrial fibrillation, even if they weren't in atrial fibrillation, an event monitor is sort of the standard of workup for these patients because it helps to risk stratify them for sudden cardiac death. So based on certain risk assessment, we may consider a primary prevention ICD in these patients. And the things that would sort of help risk stratify is if their septum is greater than 3 centimeters, they have a personal history of unexplained syncope, a family history of sudden cardiac death, late gadolinium enhancement on a cardiac MRI. So that's also sort of part of our diagnostic workup. And then if they have significant non-sustained VT on an event monitor, and then an abnormal blood pressure response to stress. So an event monitor, even if they didn't have AFib, would be part of the workup for someone diagnosed with HCM. And then the treatment for HCM, again, even if the patient didn't have atrial fibrillation, but they do have an LV outflow tract obstruction, is beta blockers and non-dihydropyridine calcium channel blockers, because these are negative inotropic agents and negative chronotropic agents. So if you decrease their inotropy, they're squeezing not as vigorously, and so their cavity has some time to fill, increase the preload, and then increase the cavity size and decrease the obstruction. So that's really the upfront treatment attempt. You also want to try to avoid diuretics and afterload reducing agents, which can be hard if they also have bad hypertension. And then mavacamten is a new medication that has come out for HCM as well. And then genetic testing is indicated for family screening. Okay, so we'll move on to the next case. We have a 67-year-old male who presented with sudden onset of shortness of breath. He also reports that about 1 week ago, he had an episode of substernal chest pressure with associated nausea and diaphoresis. He did not seek medical attention at that time. He continued to have some exertional chest pressure since that time and then developed this acute onset shortness of breath today. He has a past medical history of tobacco use, hypertension, hyperlipidemia, and diabetes. On exam, he is noted to be in respiratory distress. His blood pressure is 90/55. His heart rate is 110. His O2 sat is 90% on 3 liters, and his physical exam reveals elevated JVD and an early systolic murmur at the apex, as well as diffuse crackles on lung exam. The chest x-ray reveals pulmonary edema. The EKG I'll show next. And so the question is, what is the most likely diagnosis? Is it acute STEMI? Is it mitral regurgitation? Is it a ventricular septal defect or aortic stenosis? And here is the EKG. And then I will go back to the question. All right, so it looks like most people are saying A. Okay, so that's kind of the trap that I was kind of hoping you might all fall into. The answer is actually B. So the details here are really in the question stem. So this patient had chest pain a week ago that they kind of ignored. And have been having chest pain since then, but really they're coming in now because of this acute onset of shortness of breath. Clearly, the patient is volume overloaded. Their JVD is elevated. They have pulmonary edema. They're hypotensive. And so this just speaks to the fact that this is not an acute STEMI. If patients come in with, acute chest pain, just started, an hour ago, for example, if this patient had come in a week ago, they would present with chest pain, ST elevations, but they would not really be presenting with elevated JVD, for example, because these patients, they're acutely occluding their coronary and they don't really have the time to start developing elevated JVD and things like that. They may have pulmonary edema because that acute STEMI causes sort of this diastolic dysfunction and can cause acute flash pulmonary edema. Um, but they wouldn't necessarily have the full body volume overload with elevated JVD and things like that. And then on the EKG, what you see is that the patient does have ST elevations inferiorly, but also they do have Q waves. And so based on the patient's history, of presenting late, kind of ignoring their chest pain a week ago and having these Q waves. What you might also see on their, troponins, which I didn't include, is that perhaps they're coming down, not going up. And so all of these things may suggest that this is not an acute STEMI, but really a late complication of a missed MI. And so when patients present late for an MI and they have sort of the subacute presentation of an MI, these are actually the patients that I worry about the most. We may revascularize them and things like that, but what we worry about is these mechanical complications of an MI, which typically occur around 3 to 5 days after patients have sort of missed an MI, right? Which doesn't happen that often in this day and age. We have early STEMI protocols. We get patients revascularized early, but there's always those patients that kind of ignore their symptoms and come in late. And so what they're at risk for and what we really have to watch out for them, let's say even post revascularization, is these mechanical complications. So an ischemic VSD, a free wall rupture, which free wall rupture often they don't survive and we don't really even see them. But if someone, let's say, had a small pericardial effusion on an echo, we might be concerned about a contained free wall rupture. And then papillary muscle rupture. And so papillary muscle rupture is going to cause acute mitral regurgitation. And the murmur, as you remember, was not holosystolic, but early systolic. And so that is acute mitral regurgitation. And again, these complications typically happen in the first week of an MI when they sort of present late. So in terms of papillary muscle rupture, the inferior aspect to the MI is important because the anterior lateral papillary muscle is supplied by both the LAD and the RCA, whereas the posterior medial papillary muscle is only supplied either by the circ or the RCA, depending on the dominance. And so that's the one that's most prone for rupture. So if you have an inferior MI, those are the ones that are kind of most commonly think of them potentially having a papillary muscle rupture. And these patients can present with acute pulmonary edema and from the mitral regurg and cardiogenic shock with low output as well. And again, the murmur is early systolic, not holosystolic, which would be more in chronic MR, as there's that early rapid rise in the left atrial pressures with acute MR. Okay. On to the next case. We have a 72-year-old male with a past medical history of treated pulmonary tuberculosis who presents with progressive dyspnea. On exertion, he has lower extremity edema and abdominal distension. On exam, the blood pressures are 110s over 80s. The heart rate is 90. He has significant 3+ pitting edema to the thighs. His JVD is elevated to the mandible and increases with inspiration. And the lungs are clear to auscultation. The liver is enlarged and there is noted ascites on exam. The echo reveals a normal EF with mild concentric hypertrophy, a normal RVSP, severely elevated RA pressures with a dilated and non-collapsible IVC. There is no pericardial effusion. There is also a slight septal shift noted with inspiration. So what is the diagnosis? Is it A, cardiac amyloidosis, B, restrictive cardiomyopathy, C, constrictive pericarditis, or D, pulmonary hypertension? All right, so looks like the group's kind of split here, but most are saying B, restrictive cardiomyopathy. So let's just kind of go through the different answers. So cardiac amyloid and restrictive cardiomyopathy are, cardiac amyloid is a type of restrictive cardiomyopathy. So probably the answer wouldn't be one of those because it'd be hard to differentiate between those two things. They're kind of, similar or the same. So constrictive pericarditis or pulmonary hypertension, well, I did tell you in the question stem is that the RVSP was normal. So it really shouldn't be pulmonary hypertension. And then the key thing in this question stem is the pulmonary tuberculosis, which is a risk factor for developing constrictive pericarditis down the line. And so the question really is restrictive cardiomyopathy or constrictive pericarditis? This patient is presenting with very much right-sided heart failure symptoms, enough that they're having ascites, total body volume overload. And so this is really consistent with constrictive pericarditis. Additionally, the JVD that's elevated but increases with inspiration is classic for constrictive pericarditis. It's Kussmaul sign. So normally in patients, when you take a deep breath in, you increase your RV filling. And so your JVD should go down because you're filling your RV. But in someone who has constrictive pericarditis, in inspiration, your RV tries to fill, but it's up against this sort of stiff ventricle because it can't expand because of the pericardium, and therefore the the JVD goes up. So that's the Kussmaul sign. So the pulmonary TB, the Kussmaul sign, the lack of elevation in RVSP, and then sort of the presentation with ascites all points towards constrictive pericarditis. I do have a video of Kussmaul sign, but I won't share it for now, just in the interest of time. And then the major risk factors or sort of buzzwords that you might see in the question stem for constrictive pericarditis are prior open heart surgery, prior pericardial effusion, especially if it's a complex pericardial effusion, like a bloody effusion or very inflammatory effusion, a history of tuberculosis, and then chest radiation. And then in terms of the hemodynamic impact, is that you get equalization of all chambers of the heart because they're all equally encased in this strict pericardium. And so each chamber cannot relax independently and fill independently of each other. They're very much interdependent. And so you get this interventricular interdependence or discordance, which can be seen as the septal shift on an echo, is that when you inspire, you try to fill your RV, but you shift your septum to the left side because that RV cannot sort of independently relax and fill on its own. So it pushes the septum to the left. And with expiration, the opposite occurs. So some other signs of constrictive pericarditis just clinically is that they really just present with really right-sided congestion, lower extremity edema. Oftentimes ascites is sort of, they're misdiagnosed as just having cirrhosis from whatever etiology, but it's really cardiac cirrhosis from pericarditis. And that's just due to the very, very high right atrial filling pressures over time. Okay. Case 9. see the time. So we have a 35-year-old male with a past medical history of tetralogy of Fallot with prior surgical repair. He is unclear of the type of repair that and he has not followed with a cardiologist for several years. He is presenting with progressive decreased exercise capacity. On physical exam, he has an elevated JVD with a parasternal heave at the left sternal border. S1 is normal, and S2 is single with a soft early systolic murmur at the second left intercostal space. There's also a grade 3 out of 6 diastolic decrescendo murmur at the left sternal border that increases with inspiration. So what is the most likely diagnosis? All right, so it looks like most people are saying D, and that is the correct answer. So tetralogy of Fallot is four different things. So you have the overriding aorta, pulmonic stenosis, a ventricular septal defect, and RV hypertrophy. And the thing in at the beginning of when the patients are diagnosed that's going to affect their management is really the amount of our pulmonic stenosis. That really dictates the type of repair and replacement they're going to get, as well as the complications that they're going to have down the line. Um, and so essentially it depends. Do they have subpulmonic stenosis or actual pulmonic, valve stenosis itself? That would dictate whether they're going to have a pulmonary valve replacement, a pulmonary valve repair, a conduit with a valve in it. And so all of those things, in however way they repair that pulmonic stenosis, they're going to be at risk for down the line developing pulmonary regurgitation because that whatever repair that they did is going to eventually fail at some point. And so the murmurs that we're hearing is this basically, when you have this pulmonic regurgitation, it's this large volume load to the RV. And as a result, you get this RV dilation. You already have the RV hypertrophy from the tetralogy of Fallot itself, but you now have this dilation too. And the RV starts to fail. So you have signs of RV dysfunction, elevated right atrial pressures, JVD, the RV heave. And then in terms of the murmurs, the 3 out of 6 diastolic decrescendo murmur, I think the diastolic murmur made people think mitral stenosis, but really what that is the pulmonic regurgitation. And it increases with inspiration because you increase the negative intrathoracic pressure. And then that soft early systolic murmur, the second left intercostal space, is the pulmonary flow murmur. But because you have all of this blood going back and regurgitating, there's also increased blood flow going forward. And so you get that pulmonic flow murmur. So the boards will test you a fair amount on congenital heart disease. And so it's helpful to kind of make some quick associations. So tetralogy of Fallot, think pulmonic regurgitation is a frequent complication. That would be kind of one, kind of pattern to note. Okay. Looks like we still have some time. I think I have 2 cases left. Maybe, we'll just do one and depending on how many questions we have. Okay, so case 10, you have a 32-year-old female who presents with progressive palpitations and 1 episode of syncope last week. Today, she again had a very persistent palpitations and associated dizziness. Her vitals are noted for a heart rate of 150 and blood pressure of 110/75. Her physical exam reveals an irregular rhythm, and here is her current EKG. I'll show that for a second. This is her prior EKG. And the question is, what is the best medication to administer to treat this? Is it A, IV adenosine, B, IV metoprolol, C, IV procainamide, or D, IV diltiazem? All right, so looks like most people are saying A. Um, and the correct answer is actually C, procainamide. So if you knew nothing about cardiology, but you at least knew the drug classes, you know that A, B, and D are all AV nodal blocking agents. And then procainamide's not, it's different, right? And so we are going to exclude the use of an AV nodal blocking agent because this patient has WPW syndrome. So on the second EKG, you see that the patient has a short PR interval and this delta wave. And that is, classic for WPW. And the reason that the patient gets this is because in WPW, they have this accessory pathway. So this other sort of road, so to speak, that the sinus node can go down to then excite the ventricles. So when it goes down the AV node, like a normal person would do, the AV node has this gatekeeping property that slows conduction. But the accessory pathway does not have that, and it can rapidly conduct things. So when you have a sinus wave, it will go down both pathways, and therefore you get this pre-excitation. You get this short PR interval because the accessory pathway allows the QRS to sort of start quickly. And then you have this slurred upstroke because it's the combined kind of AV node and accessory pathway excitation of the ventricles. So this is very classic for WPW, short PR and a delta wave. And what happens when these patients happen to go into atrial fibrillation? And that's what the first EKG was, is it was irregularly irregular and wide. And what happens is when these patients go into their atrial fibrillation, the atrial activity can reach upward of 500 beats a minute. And normally, if you have a normal AV node, you will go fast, but there's a certain limit because your AV node is able to kind of slow things down that it won't allow you to go 300 beats a minute. But because you have this accessory pathway, all of that pre-excitation can be accepted by that accessory pathway and kind of really bombard the ventricle. And what happens if you give them an AV nodal blocking agent is you block the AV node, and that's what you would do for normal AFib, for example. But now all the blood flow or all the electrical current is going to go down the accessory pathway. So the patients will actually conduct even more rapidly and then sometimes degenerate into VF. So you don't want to give an AV nodal blocking agent. And so all of these agents are AV nodal blocking agents. So you would want to use IV procainamide, which is actually a class 1A antiarrhythmic drug that would hopefully convert them out of AFib. And the next answer would be if they're unstable at all, you would just cardiovert them. So I think since we're kind of running low on time, I may not go with the last question and just see if there's any questions in the chat. Let's see. I don't see any questions in the Q&A, but if anyone wanted to unmute and ask some questions, feel free. All right, looks like there's no questions. So good luck with the boards. Again, cardiology is pretty heavily tested, but hopefully this was helpful. I would, review all the guideline-directed medical therapy for heart failure, and then the practice questions will kind of help you with the congenital things and some of the more obscure questions.
Great. Thank you so much. That was fantastic. Very thorough.